Hello and welcome back. Today we're going to be talking about anxiety disorders part 2, primarily focused on generalized anxiety disorder, and we'll also touch on obsessive compulsive disorder, which used to be categorized under the anxiety disorders, but as you'll see with some more recent research, it now has its separate category onto its own. So generalized anxiety disorder is what the name suggests. It is anxiety about a lot of different things. So the symptoms include excessive anxiety and worry about a number of events, such as family, finances, work, and illness for 6 months or more. So unlike some other anxiety disorders, many of these things are actually stressors that are going on in somebody's life. You can have stressful events in your family, work, finances, and illness, and you can be worried about them. However, you can have a diagnosis of generalized anxiety disorder when you are worrying most of the time or more time than not for a period of 6 months or more. You have trouble controlling the worry, and the anxiety and worry are associated with restlessness, feeling on edge, easily fatigued, difficulty concentrating, irritability, muscle tension, and sleep disturbance. As you can see from the symptoms, these are not uncommon symptoms for people who are generally experiencing a lot of stressors in their lives. The clinical presentation can be somewhat a chronic worrywart, although many of those things can be realistic stressors, although some people worry more about those than makes sense. The people describe feeling that the majority of their days they feel tense, distractible, irritable, restless, on edge, and so they feel fatigued and mildly depressed. They report that their anxiety is diffused and unfocused, kind of free-floating and ongoing, and so there's really not a specific focus necessarily. You may see a lot of physical symptoms, and sometimes people get diagnosed with generalized anxiety disorder because they're coming from medical help. They may have things like sweating, dizziness, clammy hands, tachycardia, meaning your heart is racing. When the physical symptoms are dominant, they often consult medical specialists. And so, as I said, many times people will think they have a physical problem, when in reality it is kind of the anxiety that is causing the physical symptoms. And it gets to be to a point where it impairs their social and occupational functioning. In terms of prevalence and course, it usually has an early onset in the 20s and 30s. It's a chronic course similar to some of the other anxiety disorders, with about 1/2 to 1/3 of people remaining symptomatic even after treatment. So that kind of goes to the more characterological things, that some people just have a tendency to worry more than others. And it can be associated with significant functional impairment, because if you think about like the sleep disturbances, when you don't sleep well, that impacts so many other aspects of your life. In addition, the problems with concentration and focus make it very difficult for people to work and to engage. We see that across the globe, 20% of people will suffer from anxiety disorders in general, and in the US, 6.8 million people are affected by generalized anxiety disorders. About 6% of adults will have it at least one point in their lives, and women are more likely to suffer it experience it than men. We also see high comorbidity with major depression, as we saw in the other anxiety disorders, and you will also see here there's comorbidity with a lot of other things like alcohol use disorders, PTSD, major depressive disorder. And so when people have other comorbidities, the prognosis and the functioning is generally poorer. So if you have major depressive disorder and GAD, the prognosis is worse. You'll also, similarly, if you're using kind of substances to cope, the prognosis is worse. We know relatively little about the etiology of GAD. It was kind of considered to be, and that's partly because in DSM-3, when that was, if you recall, when we started doing a lot of research, that period of time, it was considered to be a residual category for the anxiety disorders. And so people were often assigned here kind of as an NOS, basically when they had anxiety, but it didn't fit any of the other anxiety disorders that we talked about last time. Until the last few DSM editions, like DSM-4 and 5, it made it a little better, like we understand a little bit more about GAD. However, from DSM-4-TR to DSM-5, the criteria have remained virtually unchanged. They think that there might be, kind of an overlap with temperament. such as what we saw in some of the other anxiety disorders, like the social anxiety disorder, the behavioral inhibition, general negative affectivity, and harm avoidance. But these, are underlying a lot of disorders that experience anxiety in general, so they're not specific to GAD. Based from a cognitive perspective, it's individuals may hold negative and positive beliefs about worry that predict worry in GAD. So the positive beliefs is worry is helpful; it'll help me cope. I sometimes have this, like sometimes I like to expect the worst because it prepares me, and so therefore, if the worst should happen, I'm not utterly shocked and I know how to handle myself. The negative beliefs, the worry about worry, the concern with worry thoughts, centers like people feel things are out of control. There might be, there's danger, and then they start worrying about their worrying, and that's called meta worry. And so the meta worry is a unique kind of worry that is unique to GAD, individuals who experience GAD. So the worry about the worry. I'm worried that I'm worrying too much, and then it causes more worry because you're now worrying about worrying in addition to all the other things that you're already worrying about. Some other theories of the etiology of GAD, kind of behavioral factors. So, similar to some of the other anxiety disorders, there's attentional bias towards threat. They appraise danger, and their ability to cope is kind of distorted. They tend to catastrophize. So people who have GAD tend to be, think about the worst, and they overestimate the feared consequences. And so they have contrast avoidance model. So this is kind of what I described that I experience, where I worry to prepare me for negative life events, and it avoids, therefore, the increase in negative emotions should those feared consequences occur. So I am always prepared, although I hope I don't have GAD. And it then leads to misguided coping strategies. So it's obviously not a very healthy coping strategy to always expect the worst and prepare for it. I'm not saying that I have always the most helpful coping strategies, as my husband will tell you. People with GAD also may have emotion regulation difficulties, and so they might have difficulty identifying, differentiating, and describing emotions. So that's why you often hear about the physiological consequences, like the headaches, the neck, there's the problem sleeping, the sore shoulders, things like that. And they may accept their affective experience. Treatment is harder for GAD because it's more diffuse. And so it's harder, like unlike some of the other anxiety disorders where the anxiety is more specific, GAD is more kind of, again, diffuse because they're worrying about a lot of different situations. So it often involves kind of cognitive reappraisals and learning different coping strategies to minimize the anxiety. So let's switch gears now and talk a little bit about obsessive compulsive disorder. So as I mentioned, in DSM-4-TR, OCD was listed as an anxiety disorder. And it was, historically the Freudians thought it was kind of a fear of being guilty of religious, moral, or ethical failures, repressed sexual drives. It might be the intellectualization, kind of worries, warding off the affect associated with unacceptable ideas and impulses, or the reaction formation. However, now after doing more research and looking into the biology of OCD, most experts believe that OCD is actually not a result of anxiety. It's kind of a neurological short circuit in the brain that drives these obsessive thoughts and behaviors. Although on the surface it may look like anxiety, it's actually not. And it shares a lot with other disorders that have cognitive symptoms or preoccupation with repetitive behaviors. And so it's actually a new chapter in the DSM-5, and that reflects the increasing evidence that these disorders are related to kind of one another. So we'll kind of go over the obsessive compulsive and related disorders, which is a whole new chapter in the DSM. As I said before, it was considered to be an anxiety disorder. It is no longer. It's now kind of an entity unto itself. And there's some clinical utility in terms of grouping these disorders together, because you'll kind of see the etiology or the kind of the presentation of these is very similar. So the other disorders that are now included in this obsessive compulsive and other related disorders are hoarding disorder, excoriation, which is the skin picking disorder, substance-induced or medication-induced obsessive compulsive and related disorder, and obsessive compulsive and related disorder due to another medical condition. You also see a body dysmorphic disorder, which is where you have preoccupation with one or more perceived defects or flaws in physical appearance that are not observable or appear very slight to other people. So this would be like when people are obsessed that they have, for example, a big nose or there's a problem with their chin. And while there might be some, difference compared to maybe the average person, it is not to the degree the person is. They become fixated on it to the point where they often, seek medical intervention, will get plastic surgery for it. It is one of the most common reasons that people seek plastic surgery. Like there's a high prevalence of body dysmorphic disorder among individuals who are seeking treatment for who are getting plastic surgery. And so I think it's really important, and more doctors who do those kinds of surgeries are getting informed about it, because that might not be the right treatment for individuals is to get the surgery. And so you'll see repeated behaviors like mirror checking or mental acts, like comparing their appearance to that of others. And so this is different from, the focus on being thin that we see in anorexia nervosa. This is specifically generally related to defects or flaws that are usually non-existent. Some people think that Michael Jackson may have had a body dysmorphic disorder, that he had so many surgeries on his face. Hoarding disorder is, you've probably seen different shows of this on TV, and it's where people have difficulty discarding or parting with possessions and they feel the need to save them. They think that at some point in the future they might need them, and so they then end up with, houses or apartments that are so full of junk, or what we would consider junk. They consider them treasures, that they can't often function. And so it congests and clutters their living area, so they can't even use it for that space anymore. And it often requires intervention from other people. Other disorders that we see are trichotillomania, which is hair pulling. So people have repeated, they pull their hair when they feel anxious, which then gives them a sense of relief. And you'll see repeated attempts to stop or reduce the behavior are generally unsuccessful. Or excoriation disorder, which is skin picking. And again, this is to the point where it causes damages or scars where they keep picking and picking over and over again, despite repeated attempts to stop or reduce the behavior. And so when we talk specifically about obsessive compulsive disorder, these are obsessions are persistent, disturbing, intrusive thoughts or impulses which the patient finds illogical but irresistible. And I think here the key is that they find them illogical, because if they don't find them illogical, it could be then a psychotic disorder. Like, for example, somebody can feel the need to want to hurt somebody else, but they recognize that this is an illogical thought. And so that's what causes them a tremendous amount of distress. The compulsions are repetitive behaviors or mental acts that attempt to neutralize these obsessions. So they have this thought, and then in order to prevent it from happening, they engage in a compulsion. So they might think, I'm going to get AIDS. They recognize they're not going to, but they know if they're going to wash their hands, they're not going to get AIDS. So true obsessions and compulsions are the essential traits of obsessive compulsive disorder, also known as OCD. And it's surprisingly common in the general population, with almost 3% of individuals experiencing it over the course of their lifetime. Obsessions may appear as ideas, words, rhymes, or melodies that are annoying. They interrupt thought and are often considered nonsensical, obscene, or blasphemous by the patient. They appear as images, which are usually violent or disgusting. People might say they want to stab somebody. You'll hear mothers saying they want to hurt their children, but they know they don't want to, but they have these thoughts that flash through their head. And so this causes them tremendous amounts of distress. They know that this is not something they want to do, but they have these kind of obsessive types of thoughts. And almost all patients with OCD have obsessions, and the majority also have compulsive rituals based on those obsessions. So the compulsive rituals either are directly linked to the obsession or linked by magical thinking. So I can prevent myself from doing this if I count to 10. So 1, 2, 3, or I can prevent this from happening if I wash my hands 30 times. And so they engage in these compulsions to prevent the obsession from actually happening. So underlying most cases of OCD is some form of inflated responsibility or overestimation of threat. So something bad will happen unless I do this. So they have this obsession that something bad is going to happen, and then they have then the compulsion. By doing that, they then neutralize whatever bad thing is going to happen. There may be dysfunctional beliefs about perfectionism or intolerance of uncertainty, and then there might be exaggeration of importance or thoughts or need to control thoughts. And so you might see that kind of thing often in OCD as well. Like there might have to be rigidity in terms of organization, things like that. And there are four main categories that people with OCD fall into. They're the washers, where they fear contamination and usually have cleaning compulsions. And you'll see if you look at people who have a hand washing, like their skin is often raw because they wash so often. They generally say it's about 2 hours a day that people spend doing compulsions in order to kind of meet diagnostic criteria. All of us might have some of this magical thinking, like, if you wear your lucky shirt, then it's going to be okay, or you have to turn the light on and off a couple of times, but it doesn't take up more than, like about 20 seconds of your day. But people who have OCD will go back and keep checking and checking and checking to the point where they are late for work. They're spending, upwards of 2 hours a day doing these behaviors. So checkers are repeatedly checking things like ovens being turned off, doors being locked, and it can be 20 times or more a day. But so the point where they're aware they need to be and they have to go home and check again. Doubters and sinners fear terrible things will happen if everything is not perfect. They're more likely to be paralyzed into inaction than to have compulsions. So they just kind of have these constant fears that this is going to happen. Encounters or arrangers are ruled by magical thinking and superstition and mental rituals. So I need to do this so something bad won't happen. So they'll be counting to a certain number or have different types of rituals or superstitions. So in terms of the clinical course, 2/3 of patients have substantial symptoms before the age of 15. So it comes on generally in childhood. Men develop OCD earlier than women. Men have a higher prevalence earlier on, and women kind of later on in life. The first psychiatric contact is usually around the age of 27, and then if it gets bad enough, people might be hospitalized in their 30s. It tends to be gradual, but then can get worse if something very stressful is going on in somebody's life. And for the average patient, it's generally a chronic life course, but it waxes and wanes. And usually in times of stress is when you see it getting worse. So it's estimated that somewhere between 2 and 3% of people will have OCD over the course of their lifetime. Currently, about 1.2% of US adults have OCD. Half of people with OCD have severe impairment where it's really affecting their lives to the point where they might not be able to work. Only 14% have mild and about 1/3 have moderate. Overall, OCD rates are higher in women than men, like all the other anxiety disorders we saw. However, men tend to have earlier onset than women. It's estimated that 10% of people with OCD will question their sexuality, and those between the ages of 18 to 29 have the highest levels of OCD. It does respond to treatment, exposure and response prevention. So you kind of make the person expose themselves to their worst fear, and you prevent them from engaging in the ritual. And doing that can significantly decrease the symptoms to the point where their lives can be manageable. It is difficult and it's a hard treatment to do, and it requires, a trained therapist and somebody who is willing to do this, because it's really very challenging work. And people might drop out, and it might take several times before they actually do it. Though biological research indicates that there are structural abnormalities in the frontal lobe, basal ganglia, and anterior cingulate cortex of patients with obsessive compulsive disorder. So it has much more of a biological basis than the other anxiety disorders. And so if you look at the MRI below, you can see the brains of somebody that the top is kind of a normal control condition. The bottom is somebody who has obsessive compulsive disorder. And you can see that there are significantly different areas of the brain that are lit up. Kind of, you see the frontal lobes, and that basal ganglia area really differs between those in the normal control condition and in those in the OCD condition. It generally runs in families. Concordance rates for monozygotic twins are 70% and 50% for dizygotic twins, which basically indicates that there's some genetic transmission that's involved. And individuals who have OCD have a 1/4 chance of having a first-degree relative who also has OCD. So again, this is why they separated out OCD from the other anxiety disorders, despite the fact that the treatments both have exposure bases to them. We see a much stronger biological underpinning or etiology for those who experience OCD. You need to, in terms of differential diagnosis, look at normal obsessions and compulsions. And people who have obsessive compulsive personality disorder, like Monica on Friends, generally do not have true obsessions and compulsions. They just like to have things neat or whatever, but it's not the same degree as somebody who has OCD. Compulsive gambling, eating, and sexual behaviors are not true compulsions, so that's not the same thing as OCD. People who have schizophrenic delusions may resemble obsessions, but again, here's where the catch is, that people who have schizophrenia generally don't realize the irrationality of their obsessions or their delusions, but those who experience who have OCD generally do. Also, oftentimes for people with schizophrenia, the delusion might be egosyntonic, meaning that it goes along with their mood versus it doesn't necessarily cause them distress. But those with OCD, have ego dystonic, so they don't want to have those thoughts or those beliefs, and they get very distressed by them. And you can imagine that given the nature of the disorder, major depression is often comorbid, but can also be confused because people who are really depressed tend to ruminate, and the rumination can sometimes take on a delusional flare, which can also present as OCD. So it's important when you're doing a differential diagnosis